Hi, my name is Dr. Joseph Morungu, the Deputy Program Director for HealthCall. I'm going to take you through this module that focuses on other types of cascades, and we're going to demonstrate how the cascade methodology can be applied to other areas of care. And in this presentation, I'll talk about the disaggregation of cascades by age, gender, and geographic areas. And I'll give some specific examples for key populations. We'll also talk about HIV prevention cascades, giving an example of oral pre-exposure prophylaxis, as well as the prevention of mother-to-child transmission of HIV, PMTCT. Here we illustrate how the cascades can be used to compare progress across the cascade among different age groups. And in this example, we look at adults, adolescents, and children. So from this example, you can tell that identification of children, which is at 79%, and 74% for adolescents living with HIV, is lagging behind compared to adults at 81%. We can also see that AD coverage is high across all population groups. However, viral suppression is lowest among children at 77% compared to the national average of 92%, as well as 81% and 86% for adolescents and children and adults, respectively. Here we also illustrate how the cascades can be used to track progress over time, looking at the years 2016 to 2018. And you can actually compare year-on-year performance across the steps of the cascade towards the UNA's global targets. In this example from Jakarta, we use the cascades to track epidemic progress in different subpopulation groups, which we again underscore as critical for targeting program interventions. So in this example, we compare performance across the cascade among men who have sex with other men, and female sex workers, as well as transgender persons and people who injected drugs in Jakarta. PMTCT is also a critical intervention, and the WHO comprehensive PMTCT approach involves the prevention care and treatment of two people, the mother and the child, best viewed as longitudinal cascades. So in this comprehensive intervention, there is ART for life for the pregnant or breastfeeding women who are living with HIV. There's also ARV prophylaxis for the HIV exposed infants, as well as diagnostic testing for the exposed infant with subsequent initiation of treatment if found to be infected. So all pregnant women with a known or HIV status should be screened at the first antenatal visit, and this is then highlighted in this example as the first step of the cascade. So the PMTCT cascade is used to track progress towards elimination of mother-to-child HIV transmission, as well as to identify types of services where the improvements in coverage and quality are needed. We know that in 2015, 6 priority countries that include Botswana, Mozambique, Namibia, South Africa, Swaziland, and Uganda met the global plan target of reducing mother-to-child transmission by 90%. Outside of the priority countries, in 2015, Cuba became the first country to eliminate mother-to-child transmission of HIV. In 2016, Belarus and Armenia achieved the same feat, while Thailand became the first country in the Asia and Pacific region to eliminate mother-to-child transmission of HIV. These PMTCT cascades from Namibia show how the steps of intervention for HIV pregnant women and separately for HIV exposed infants can be used to identify gaps in performance. High rates of ART are noted, although the rate of skilled deliveries is suboptimal. Low rates of HIV transmission are also observed with a gap in starting infants on treatment. In this different example, we also look at the PMTCT cascades from Kigali. And this cascade demonstrates a highly successful PMTCT program, but also tracks testing of partners of pregnant women, highlighting a rate of nearly 86% and an area for targeting improvement. Shifting now onto HIV prevention cascade. The example here highlighted reflects the complexity of HIV prevention cascades, which is apparent in this figure in terms of how we can then calculate the numbers of people who would benefit from a prevention intervention, those who want to use it, and those who can access it or not, require special surveys or extrapolation for other databases. However, the framing of prevention in this format, like the care and treatment cascade, helps to conceptualize and prioritize strategies, identifying gaps for the most effective use of resources. Here we see the adaptation of the cascade methodology for PrEP, a central strategy to reducing new HIV infection. You can see the steps along this cascade which require either surveys or qualitative interviews to obtain information, such as the second and the third step, which focus on awareness and willingness to be initiated on PrEP. The steps are important areas to target for interventions when gaps are identified. This is a slight variation of the PrEP cascade by population group used in Kenya, also highlighting the different population groups, including female sex workers, men who have sex with other men, and adolescent girls and young women. Of those who are eligible, only 25 to 35% have been initiated on PrEP. Disaggregation by key population is also illustrated in this example, with high rates among adolescent girls and young women and lowest rates among men who have sex with other men. Some of the challenges that you may come across as you develop cascades for key populations include a lack of sufficient data in most countries to construct HIV cascades for key populations, as they may not have readily available data on size estimates or estimates of the percentage or the percentage of the population group that are indicated for the intervention. While HIV case reporting data are disaggregated by mode of transmission, in many concentrated epidemic settings, sex work is generally not disregarded from other sexual risks, making care cascade estimates among sex workers a particular gap. And then in utilizing population-based surveys that focus on key populations to estimate care cascade outcomes has been suggested as a means to overcome this obstacle. So in conclusion, engagement in care is critical to the successful management of HIV infection, for the individual and also for the population. The HIV treatment cascade provides a framework for assessing and improving programmatic implementation and management so that outcomes at each step can be maximized. The HIV treatment cascade can be targeted based on the context, the setting, the needs and data sources, as well as understanding of population trajectories critical for maximizing ART benefit. Thank you.